possibilities of treatment for thoracic outlet syndrome. So first of all, what do we call thoracic outlet syndrome? It's basically a dynamic entrapment that involves the proximal brachial plexus, the subclavian vein and artery. The thoracic outlet is the region that is between the cervical spine and the inferior border of the pectoralis minor. And here there are basically three sites where you can have a compression of the neurovascular bundle. The interscalenic space, the costoclavicular space, and the interpectoral space. So before we are going to start to talk about the clinical presentations of these syndromes, I think we better review a little bit the anatomical borders. So, the scalene muscles are basically a group of three muscles, anterior, medius, and posterior. Sometimes there might be a fourth muscle called Simpson muscle, which is present behind the lower portion of the scalenus anterior. The scalene muscles are accessory muscle in inspiration, and the anterior and the middle scalene delimit a potential space which is known as interscalene space, where you have the brachial plexus and the subclavian artery. So here you have the brachial plexus, and remember that the subclavian artery is behind the anterior, the scalenus anterior, whereas the subclavian vein is actually anterior to the anterior scalene. The other two signs of compression are the space between the first rib and the clavicle, that is called costoclavicular space, and then the interpectoral space is actually the space behind the insertion of the pectoralis minor on the coracoid process. So, DOS is actually classified in three forms: the neurogenic DOS, the arterial DOS, and the venous DOS. We are briefly speaking about the two vascular forms. Arterial DOS affects just a minority of patients and is given by a compression of the subclavian artery within the scalene triangle that might lead to development of occlusions or aneurysm. Arterial DOS generally present a sudden onset with hand pain and weakness, numbness and tingling in the ends of fingers, and the patient can present cold and pale fingers, claudication. And treatment is based on anticoagulation, and there can be surgical treatment consisting of resection and rough reconstruction. Venous DOS is a little bit more common, affecting 10-15% of all patients. And a peculiar clinical presentation is the so-called thrombosis or Paget-Scheffer syndrome, which is basically due to repetitive compression of the subclavian vein during activities involving arm elevation and causing epiphyseal thrombosis. Basically, it occurs in young people. So again, the clinical presentation is generally with a sudden and abrupt spontaneous swelling of the entire arm that can get a bluish discoloration and becomes heavy and painful. And treatment consists of thrombolytic therapy followed by anticoagulation that might be required also lifelong, and then you have angioplasty and surgical possibilities. So now let's talk about neurogenic DOS, which is actually the most important, statistically speaking, form of DOS, because it involves up to 95% of cases, and definitely the vast majority of these patients are women. This kind of entrapment can be bilateral in 10% of cases, and just keep in mind that there is an higher prevalence of the right side. Now, neurogenic thoracic outlet syndrome sometimes appears in ladies that present typical physical features. They might have long and slender neck, narrow shoulders, and often, I would say, in half of my patients, there are heavy breasts. There might be anatomical factors that seems to give a predisposition to development of this entrapment syndrome. Bone anomalies that are actually occurring in the normal population with a very low incidence and seems to be more present on the left side. So this should ring a bell in your mind, because previously I actually mentioned that TOS occurs more frequently on the right side. So this is already the first sign that a bone anomaly does not mean that you're going to have a patient with a TOS. The bone anomaly supports your idea of having a TOS, but it's not the indication to diagnosing a TOS. Bone anomalies have already been classified in the 19th century by the German anatomist Gruber in 4 types, and the third one is definitely the most common in the patients. They might be associated with the muscle anomalies, and there are interesting relationships between the bone anomalies and the brachial plexus, because prefixed plexus are often associated with cervical rib, whereas postfixed plexus is often associated with anomalies of the thoracic rib. As I mentioned before, we might have muscle anomalies, and they are listed here. But there are other factors that are definitely more important to be considered when you're dealing with a patient where you suspect there might be such a syndrome. A lot of patients will start